it's not going to be any long lecture. It will be straightforward because we basically discussed every topic that we need to discuss. What we are doing now is just a revision basically of the management. We are just going to take a look at the management processes. So we won't bore ourselves to go through, everything from the beginning till management. We'll just do a small reminder of what we've learned, and then we will discuss the management aspect because that's the most important thing now. So let's talk about atrial fibrillation. I hope you can see my screen. Since it's the first topic on our topic list, we'll just talk about it. So I just want to know if we still remember what we said about atrial fibrillation. So anybody at all can tell me one characteristic or what they remember about atrial fibrillation. Oh, we didn't revise before coming.
Yeah, it's also referred to as supraventricular fibrillation.
Okay, it's a type of supraventricular. It's a type. It's one of the supraventricular tachyarrhythmias. Okay, that's good.
Okay.
Okay, any other?
So we said it can be tachyarrhythmia or bradyarrhythmia.
But that is looking at arrhythmia as a whole. But atrial fibrillation, as Achu said, you are looking at it as a, okay, Achu said it's a supraventricular arrhythmia, a type of supraventricular arrhythmia, yes. So once you are talking about arrhythmias, it can either be slow or it can be fast. But in terms of atrial fibrillation, your focus is on a tachyarrhythmia, but not a bradyarrhythmia. Bradyarrhythmia means it's slow, but atrial fibrillation won't give you slow rates. One characteristic feature is that you would usually have a faster rate. Okay, so it's a tachyarrhythmia, but not a bradyarrhythmia. Well done for trying. Any other? Because if you don't remember, then it means that we have to start the lecture all over. And that will be 0/100 for us in terms of what we've done in the past. Okay, let's run to,
sir,
yeah.
I want to talk a bit about the symptoms. Has no symptoms, but sometimes something like fatigue.
Okay. Yes, so looking at the symptoms, yes. In terms of investigation, looking at what atrial fibrillation basically is, the fact that we're saying that it's a tachyarrhythmia, presents with, apart from the fast heart rate, it also presents with an irregular heart rate. What is the striking feature you expect to see when, okay, let me ask this question first. How would you have a patient coming to you and you are thinking, well, this could be atrial fibrillation because you've touched the patient's pulse and you've realized that basically the pulse is irregular, okay? And the pulse is very, very fast. How would you be able to confirm your diagnosis that indeed this patient has atrial fibrillation?
Yeah, so please, I think ECG, doing ECG can help with that.
Excellent. So that's the basic thing that we do. Basic but life-saving. So do an ECG for our patients. Well done. And what is the striking feature of an ECG pointing to atrial fibrillation?
I think with the scene, the P wave, there will be a deviation at the P wave.
What will happen to the P? Something will happen to the P wave. What will happen to the P wave?
It will be invented, like it will point downwards.
Are you sure?
Try. It will flatten. It will be flattened.
Okay.
There'll be an irregular interval between the P waves.
The question is, will there even be a P wave at all?
The P wave will not be there.
I remember you said something like, say.
Yes, Evans.
I remember you said something like long, or like long, or. Hello.
Yes, hi. We can hear you, Evans.
Yes, I remember you said like the P wave. There will be something like a long drop. You made mention something of.
Okay, so you are talking about Hertz block. You're talking about Hertz block. Okay.
Oh, okay.
You're talking about Hertz block. So the P wave will basically be absent, or it will be very discrete. Okay, so you may not see the P wave. And then, can someone tell me the reason why? I think I heard someone say it in the background.
Because of the rapid way the atrium is contracting, it doesn't contract fully to get to generate that wave to get to that peak.
Good. Well done. Okay, I think we have to do some quick revision on the normal ECG just to remind ourselves. And then we can go on briefly.
Okay.
Okay, can you please see my new screen?
Yes.
Yes, sir.
All right, okay, good. So we all know that when you let's take this picture, it'll make things a bit easier. If you follow my cursor here, when we take this, basically you take the ECG strip, right? You see something basic like this, okay? This is something basic that you see on the ECG. And from here, where this arrow basically is, okay, to here is one cardiac cycle, okay? From here to here is another cardiac cycle. From here to here is another cardiac cycle. So to understand ECGs and to understand how your sheet, you should know that basically the heart would what? contracts and what relax. It goes through a cardiac cycle. And in the phase of a cardiac cycle, you have what we call what atrial contraction, atrial relaxation, ventricular contraction, and ventricular relaxation, right? I'm sure we all remember that.
Yes, sir.
Yes.
Good. So for the heart to be able to basically contract, or for you to be able to, because what the heart does when it contracts is that it basically ejects blood into the systemic circulation. For this to be able to happen, what you are doing now is that you expect that blood is going to move from the atrium and then move all the way into
The ventricle.
the ventricle, exactly. There's a bit of background noise. I don't know where it's coming from. But of course, you can always unmute when you want to talk. Since you are recording for your YouTube, I think that we should try as much as possible to limit the background noise. Okay, so basically that's what you have here. So once you expect that you expect to inject blood into the systemic circulation, we are going to move the blood from the atrium to the ventricle, then it will go through and then basically go to the systemic circulation. So from the right side, you expect that the blood will move from the right atrium to the right ventricle, goes through the pulmonary artery to the lungs for oxygenation. It comes back through the pulmonary veins to the left side of the heart, and then it goes through all the way from the left atrium, left ventricle, through the aorta, and then to the systemic circulation. Basically, that's a cardiac cycle. When you take a look at it, okay, you need the atria to contract. And the point where the atria contract is what we call that P wave, okay, if you remember. And then after the atria contracts, then the ventricles will contract. And the point where the ventricle contracts is where you have your QRS complex, okay? And then you have basically repolarization of the ventricles. So that is what is happening here. When you take your ECG, the small peak that you see, the very first small thing that looks like a mountain or a hill, small, that you see, your P wave, basically represents contraction of the atria, okay? And your QRS complex, which is the large, long mountain that you see, represents contraction of your ventricles. If you take an ECG and you have, of course, you are supposed to remember the lecture I gave you on ECG. The P wave is supposed to have a certain time interval. If it goes beyond that, then we say that P wave is prolonged, blah, blah, it means something. QRS is supposed to have certain distance if it goes beyond that and whatnot. But if you take your ECG and then you have any issues with your P wave, then it means that you are having issues with your atrium, basically. And if you have issues with QRS complex, then it means you have issues with the ventricles. Basically, that's what it means, okay? So in atrial fibrillation, we are saying that the atrium is beating so fast, okay, and at the same time it's beating irregular. So you have it beating so fast that because it's beating so fast, it's unable to contract fully to push blood from the atrium into the ventricle. Basically, that's what is happening. So it's beating so fast that we say it is quivering. Instead of it's beating with force to push blood into the ventricle, it's like it's just playing around, just being ticklish. You get it. And in that case, because the atrium fails to contract, you are not going to have an indication on your ECG. So your P wave will be absent. And even if your P wave is present, it will be very, very discrete because the atrium has failed to contract. Okay, so that is what you tend to find on the ECG. So let's look at this image here. You can see, comparing this one where this cursor is now to what I showed you before. See, the first one had a clear P wave, okay, right before. But this time around, there's no P wave in front of this QRS complex, okay? And look at what I showed you here. The intervals between the QRS complex is what we usually measure our heart rate on. So you can see that this is the same as this, is the same as this, is the same as this. So this is a regular, heart basically beating. Now let's look at the other ECG. P wave is absent, and now look at the interval between the QRS complexes. You can see this is longer than this, and clearly it's not the same as this, which is also not the same as this. So there's an irregularity in terms of duration between the QRS complexes. So there's an absent P wave and your QRS complexes, instead of it looking all regular like this, it's not. It's rather looking irregular. Are we okay?
Yes, sir.
Any questions, please?
Okay.
Okay. Atrial fibrillation is not the same as atrial flutter. I hope you know that. Are you aware atrial fibrillation is not the same as atrial flutter?
Yes, sir.
What's the difference?
Yes, sir.
What's the difference?
For if you see the atrial flutter, hello?
Yes, hi, we can hear you. We can hear you. So unlike the atrial fibrillation, where your atrium is basically beating irregularly, it's a different scenario for atrial flutter. Even though in atrial flutter as well, the atrium is beating very, very, very fast. So you might have about 2 or 3, contractions before a ventricular contraction, as you can see, before a ventricular contraction. So your ECG actually looks like a sawtooth. So you can see, looks like the saw, if you remember your pre-technical skills, because you are getting about 2 or 3 atrial contractions before a ventricular contraction. But the main difference is that in atrial flutter, the atrial contractions are regular, but then in atrial fibrillation, your atrial contraction is irregular. Okay. All right. So now you basically get, what we've done is we've tried to discuss or define what atrial fibrillation is. We know that it's a tachyarrhythmia. It presents with an irregular heartbeat. When you look on the ECG, which is a diagnostic way of dealing with it, basically when you look at the ECG, what is happening is that you have an absent P wave and your QRS complex is also irregular. Okay, so don't forget it now. It's basically, so that's a supraventricular tachyarrhythmia, and it's characterized by irregular and rapid heart rate. That's the most important thing you should know. Atrial fibrillation has basically been found in association with a lot of cardiovascular diseases, and they are still doing research to know exactly what this association with cardiovascular diseases is about. Okay, but basically a lot of things, like maybe if there's poor perfusion to some parts of the atrium, what we call atrial ischemia, if you have any form of hemodynamic stress, conditions like diabetes and whatnot can affect the heart, and all these things will lead to abnormal contraction of the heart. If you have excessive catecholamine release, so the sympathetics are basically in overdrive, like adrenaline is high, and adrenaline is high, clearly your heart is going to beat fast and you are going to be at risk of something like atrial fibrillation. Okay. So talked about clinical features already. I won't go there. In terms of emergency medicine, once a patient comes and you are thinking this is atrial fibrillation, as we said before, you go ahead and then you do your investigation, and basically we are going to do our ECG for the patient. Okay, so as it's the first point of management, you're doing our ECG because you want to know exactly what it is. So there's no P wave, QRS complex is irregular, and the P waves have been, basically replaced with something funny, what we call the fibrillatory waves or the F waves. Okay. I mean, as part of your management, if you have echo at hand, you can go ahead and do an echocardiogram. It would help you. Okay. Why do we need to do an echocardiogram? One reason why we need to do an echocardiogram for patients with atrial fibrillation. What do we worry about the most when we say our patient has atrial fibrillation? Because I mean, hey, we don't care. Your heart is beating fast. Why are we concerned? Okay, why are we concerned if we make a diagnosis of atrial fibrillation?
Sir, please, it may lead to heart block.
Heart block.
And with that.
Okay.
Let me give a try. I think because of arrhythmias, because AF in itself, atrial fibrillation in itself causes there is rapid and abnormal, or say irregular heartbeat, and it affects the way the heart. In fact.
Hello, sir.
Yes, hi.
Yeah, I am thinking because the atrium is not contracting fully or not, each cycle is not completed. I think it will have cardiac regurgitation, where instead of the blood moving to the ventricle to rather flow backwards. That's what I'm thinking.
Okay. Okay, so it will flow backwards where? You're making an excellent point.
From the back of the ventricles into the atrium.
And when it happens that way, what will be the problem? What do we worry about?
It can lead to stasis.
Good. You are using the term I want to hear. Stasis. Stasis where?
Yeah. It can happen
because that is the term I want to hear.
Hello.
Hi.
Yeah, we have blood from the lungs coming to the atrium.
Okay.
So if the atrium is not able to pump and send it to the ventricles, it will move back to the lung.
Okay, wait, don't get to the lungs first. Before the blood moves from the atrium into the lungs, what happens in the atrium? Because eventually, if you have atrial fibrillation, you can end up developing some form of heart failure. And so basically the heart will fail to act as a pump. That is what heart failure is. So the blood that is being, basically the stasis in the atrium, the blood will end up going into the lungs, and then you have some form of pulmonary edema, difficulty in breathing. That's it. But if the heart hasn't failed yet and it's still rapidly contracting, okay, but then not pushing the blood to the ventricles, the blood would stay, the stasis would occur where? In the atrium. And what would that lead to? That is what I want to know.
Embolism.
Yeah, exactly. It will lead to something before embolism. So just complete. Yes, so it will lead to thrombosis, and then this can lead to what? Embolism. So it will lead to thromboembolism. Do you get the concept?
Yes, sir.
Yes, sir.
Great. Let me see if I can find something interesting for you. So this is very, very important. Okay, it's important. So you should be thinking about it once you make a diagnosis of atrial fibrillation. That is what you should be thinking about. Wow, patient has atrial fibrillation. It means that there's basically stasis of blood in the atrium. The atrium is contracting, but then it's contracting for nothing. You see, so there's stasis, and then whenever I hear stasis in medicine, only one thing comes in mind: Verkhov's triad, stasis, hypercoagulability, and endothelial dysfunction. That's what comes in mind. So in this case, there's stasis. Wow, so blood is staying in the atrium. So in case this patient has other risk factors, like he's hypertensive, and because of that, there's increased pressure, blah, 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 in the vessel, and you know that indirectly the heart is a form of a vessel. So this increased pressure can destroy the endothelium of the vessel. So you can have this pressure destroying the endocardium, okay, the inner aspect of the heart. Then it means you have endothelial damage. So stasis endothelial damage would lead to thrombus formation, which can lead to an embolism. Okay. Look at this screen here that I have. Can you see the screen, please?
Yes, sir.
Yes, sir.
So this is a heart that has been opened. You've basically been opened, and this is the atrium. Okay. And you can see the thrombus there. Okay, and that is what atrial fibrillation is capable of causing. Okay, so you can end up, maybe this is a schematic diagram which can give us an idea of all that I'm talking about. So you can see where my cursor is the atrium. So this is basically the left atrium. This is the left ventricle, because you can see how thick it is and all that. This is right ventricle, and the right atrium is up here. Because of stasis, you can basically end up forming, you form it here, you form a blood clot here. Okay, so do you get the concept? So
Yes, sir.
this is what I meant by, if you have an echo available, you do an echo. That is the reason why you do an echo for a patient with atrial fibrillation, because there's a risk of picking up, because the echo has Doppler and all that, the duplex feature. So you can see clearly this arrow is pointing to a clot. Ideally, this is the chambers of the heart, and it's supposed to be empty. See the way this one is empty, and here is empty. But why do we have something white here? This is not supposed to be here. So you get it. That is basically a blood clot. Thrombus sitting there. Okay. So basically that's what we worry about in atrial fibrillation. If this thrombus is on the right, what are you worried about?
Pulmonary embolism.
Pulmonary embolism.
Good. Pulmonary embolism. Why?
Because the blood will flow back to the lungs.
Excellent. So if the thrombus is here, this is the right side. The right side, blood would have to get to, basically it has to get to the lungs, okay, for oxygenation. If this thrombus is on the left, just like this, then what will happen? If it's on the left, the thrombus is on the left.
Move back to circulation.
Okay, which is what capable of leading to what?
Edema.
No. So it won't move back. It won't move back to the pulmonary circulation. Now it is here. So
it's going to the systemic circulation.
Systemic circulation, excellent. So then what are you worried about the most? Thrombus in systemic circulation, what are you worried about?
EVT.
So I'll be thinking about something like a blockage in the arteries, and then it is going to hinder an artery leading to an organ, which will eventually lead to necrosis of an organ, depending on where the block.
What organ are you worried about the most?
The kidney and the heart.
No, you are not scared of. You're not scared of things. The brain.
Yeah.
The brain is what you should be worried about. So if it's on the right and it dislodges, it's going into the lung, and you are going to develop
TVA.
You're going to develop a P on the right side. If it's on the left and it dislodges, then it's going into the brain, and you are going to develop a CVA. So it is something we worry about. You can see the images I'm projecting now. Can you see?
Yes, yes, Doc.
So you see, it's a thrombus that's moved. It's going all the way straight. This systemic circulation, it can come down, it can go up. But most of the time, because this vessel here is so huge and more blood is constantly going to the brain, that is where it will go. So it goes through and you see where it's going. That is a straight infarctive stroke there. The same thing here. So atrial fibrillation in itself would say, oh, it's just atrial fibrillation, the heart is just beating fast, the person is hyper. But the problem here is that there's the risk of you having stasis, which can either lead to a P on the right or a CVA on the left. That is one major thing you're worried about. The other thing is that the heart will beat, and eventually get tired, and you end up developing some form of heart failure. Are we okay?
Yes, sir.
Yes, sir.
Yeah. Okay, great. So now we get the concept. So if, as a clinician, this patient comes to you, you've done your ECG, you've made a diagnosis of atrial fibrillation, you've done echo, no clots. Okay, and sometimes what is worth, we want to do a chest x-ray because the chest x-ray tool would, help you see if there's cardiomegaly. You want to know if the patient has been having the atrial fibrillation for a very long time, and because of that has developed some form of, heart failure, whatnot. Okay, so your chest x-ray would come in handy. Of course, your echo would tell you if the heart is big or not, but it's good to do a chest x-ray. It's traditional and we like it. More people can read that you've done a chest x-ray. So yeah, you've made this diagnosis that the patient has atrial fibrillation. As a clinician, knowing this patient's problems, and what are the problems now? The heart is beating fast, heart is beating irregularly, and the heart's beating fast. The complication of that is fatigue and cardiac failure, basically, myocardial fatigue and then cardiac failure. The thrombus sitting in the heart, whether the left or right, with complication of CVA if it's on the left and then P if it's on the right. As a clinician, and based on what you know in medicine, how would you want to manage this patient? Patient has come to you. Patient is stable. BPs are not so bad. SpO2 is okay. Patient doesn't need oxygen. How would you want to manage this patient?
Please, I would want to give something to, let's say, take away the plaque first that has formed as a result of that, if I have a confirmation of that.
But I said you've done an echo. The echo says no thrombus or plug has been formed in the heart yet. I like your way of thinking. You want to sort, but the echo is saying there's nothing.
Oh,
do you want to give it a try? Do you want to give it another try?
So you give your beta blocker.
Sir, please.
There is irregularity in the contraction of the atrium, which is capable of leading to stasis. I will give a drug that will help regularize the atrium so that the contraction can be made proper.
Okay, I like that. Okay, so that is called rhythm control. So you would want to regularize it basically. So you want to regulate the rhythm because the rhythm is irregular. So that is rhythm control. Okay, so he says you give a drug for rhythm control, which is correct. If the exam management was over 5, he's gotten 1 already. So rhythm control. Okay, what else?
I also want to give anticoagulants in order to
Excellent.
prevent.
I like that. So that alone will give you 2 marks. So anticoagulation is key in this patient. So rhythm control, anticoagulation, and then please add the last one. What would you want to do for the patient?
Hello, doctor.
Hi.
Sir.
Give a drug to
Yeah, I would like to
improve the myocardial contraction.
Okay. How would you do that?
For example, your beta blockers.
Okay. So your beta blockers would help control what? You want to improve myocardial contraction, which I understand. So what would the beta blockers do?
There will be calcium channel blockers.
Okay, calcium channel blocker. All right, beta blocker. But what's the focus behind that?
Control the rate of the heartbeat.
Yes, so rate control. So that's the reason why you want to give what's the blocker. Because one, you want to control rhythm, as you said. You want to anticoagulate the patient, as you said, and then you want to control the rate. So basically in AF, that is our focus, okay? So that's the management. So when a patient comes to you and the patient is stable, these are the 3 things you are thinking about: rate control, rhythm control, anticoagulation. Of course, if the patient is not stable, then quickly you need to stabilize the patient, which brings us to the basis of emergency medicine. If a patient is rushed to you and patient is not stable and you need to stabilize the patient, what do you do for the patient? I believe we've all done some form of clinicals and some form of, we've been exposed to some cases one way or the other. And emergency medicine, this is the foundation of emergency medicine. You see us doing it every time when you come for clinicals. Okay, so what do we do once a patient is not stable? What is the term used? There's a general term that we usually use, which you guys also use.
CPR.
Oh, you do CPR when you make a diagnosis of cardiac arrest to get there.
You resuscitate.
Yes, that's the word I want to hear. You resuscitate. Okay. So in emergency medicine, I don't know if you're going to get any emergency questions in your MDC exam, but if you read any question, being it's pediatric, surgery, ONG, or internal medicine, and there's any bit of patients not being stable in the question, the first thing you should talk about in your management is resuscitate before you even go ahead to do the actual management or the definitive management for the patient. Example, imagine a patient has an appendicitis and this patient has been vomiting before getting to you in the facility. As a clinician, you've been able to pick up the diagnosis and you say, this is an appendix. Your boss is happy. And then your boss says, okay, prepare for surgery. You don't just take the patient just to theater. That's okay, prepare for surgery. All right, okay, come and put on the theater gown. Okay, let's make sure we scrap him well, and then let's go in. No, you need to resuscitate first before definitive treatment or definitive therapy can happen. Okay, so once you talk about resuscitation, you need to know the basic blocks of resuscitation. So tell me what resuscitation entails. We say it every time.
ABC.
Good. Good. ABC. What does the A stand for?
Airway.
Airway.
Okay. And then your B. Okay.
Breath
And then circulation.
Excellent. So hopefully once we are full back in session, and then people like UGMC agree that you come amidst COVID, we just hope that we don't have any spike. You would have hands-on training with the mannequins on how to go about your ABC. And if there's a CPR and whatnot, they will teach you. Okay, so that when you go for your clinicals, anytime you hear emergency, resuscitate, then you are thinking ABC. So as you said, airway, very, very, very essential. So as soon as a patient comes to you in management, we have what we call, or in the primary, what we call the resuscitation of the primary survey, we have what we the term assess and manage. You don't just assess, you assess and manage. So once the patient comes to you, you are thinking ABC, assess airway and manage airway. What does patient is not stable, your SpO2 is dropping and whatnot. You need to find out the cause. You won't just know. This one, we're having a lecture on atrial fibrillation. So you know that, patient is not stable because patient has atrial fibrillation. But when it happens and they bring the patient to the emergency, you won't know. You have to assess first and stabilize even before you go ahead and take your history and all that. So in the assessment, in airway, you need to look at the patient's airway, open the patient's mouth, check out for secretions, look into the nose to see if there's anything obstructing the airway, because basically the SpO2 is dropping. So it's not enough to just put oxygen in the patient's airway if you haven't assessed and managed the airway. Because what if there's an obstruction, the patient has got some secretion stuck in the airway, you're going to give oxygen. The oxygen won't get anywhere. So you get it. So this is the basis of emergency medicine. You need to assess the airway, look for foreign body, look for secretions, if there's anything that you scoop. And we apply this technique for every emergency. If you have an RT and it comes to you, patients can sometimes have the whole lose like a couple of tooth and it will just be going into the airway or whatnot, or secretions, blood and everything going into the airway. You need to assess and you need to manage. Okay, after you've assessed, then you manage. How do you manage? Now you do oxygen supplementation or oxygen therapy to push the SpO2 up. So that's airway. Then you're looking at breathing. So you want to look at the patient's chest to see if the chest is even moving at all. You want to look at the patient's respiratory rate. So that is breathing. Okay, so you assess respiratory rate, and that's what will tell you if maybe the patient is in respiratory distress. Because if patient is, then the rate will go up, or patient is in respiratory depression. And if patient is, then it means the rate will be basically low. And this is important because if, let's say, you have a patient, let me deviate a bit, who has an injury and you want to give an opioid like tramadol or pethidine or morphine to the patient because of the severe pain, and probably this patient's injury is a very severe injury that has affected maybe the CNS or respiratory centers, and patient has fallen, and patient is basically doing a respiratory rate of about 8 cycles per minute. But you say, you think patient has fallen, there's pain, so let me give a very strong painkiller. You go ahead and you give the patient an opioid analgesic. And opioids cause what? Respiratory depression. You depress the respiratory centers further and you kill the patient. So assessment is very, very essential. So assess airway, assess breathing, you are looking at chest movement, you are looking at respiratory rates. Okay, you have your stethoscope, you are putting it, you are auscultating because you want to assess breathing. And then assess circulation. So how do we assess circulation? You look out for signs of dehydration, patient is bleeding, all those things. You set a line, you start running your infusions and all that. But that's just one way of assessing and managing circulation. It can go the other way. If a patient has heart failure and you're supposed to assess and manage circulation, it doesn't mean you should pass a line and give fluid. So assessing circulation can either be both ways. Either you are deciding on giving IV fluids, you are deciding on giving blood, or you are deciding on what? Getting rid of excess fluid in the patient system. Are we okay?
Yes, sir.
Yes, sir.
Okay, I want you to remember this always. Your ABCs, assess, manage. For every case that comes to you in every medical field that you think that this case needs emergency care, ABC, always. Of course, there are other ones, D, which means add drug therapy to your treatment, and E, which means expose the patient. Sometimes your patient who has like some form of RT, or maybe your patient who has a cardiovascular condition will be wearing tight fitting clothing, and because of that would have some syncopal attack because of press on the carotid, sinus and whatnot, and then your patient will collapse and they'll bring the patient to you. You need to expose your patients, but that alone is life-saving. So that is E. And then some folks will say F, which is Foley's catheter. So you pass a catheter to monitor urine output. So they sometimes end up having A, B, C, D, E, F. And people even go on G, H, and blah, 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 and all that. But A, B, C, very essential. And after you've achieved your ABC, you can think of your drug therapy for your patients. If you need to expose or you need to clothe your patients well, if you need to pass a catheter, do that for your patient. So in terms of atrial fibrillation, as I said, if patient is stable, we are thinking of rate control, rhythm control, and what? Anticoagulation therapy. If patient is not stable, you are assessing with your ABCs and you are doing the needful. Okay. Now, let's look at rate control. As you already said, you can go ahead and then you gave your beta blockers. I gave you slides on that. So let me see if there's anything on rate control. Yeah, okay, so you can go ahead and give your beta blockers, your non-dihydropyridine calcium channel blockers, your digoxins, okay? Dihydropyridine calcium channel blockers like what? The one that we know, like nifedipine, like felodipine, like all those pins are dihydropyridine calcium channel blockers. And then the non-dihydropyridine calcium channel blockers are your verapamils and your diltiazems and whatnot, right? So in this case, for race control, we're saying give a non-dihydropyridine calcium blocker.
Sir, please, can I ask a question?
Yes, you can ask a question.
Sir, so in a case of the patient being a known asthmatic and you are serving the beta blockers, must you be a bit concerned?
Oh, yeah, you should be concerned. As I always say, you always have to make sure that you are not giving the patient a non-selective beta blocker, right? And that is why now we have lots of selective beta blockers out there on the market, like bisoprolol, like metoprolol, even atenolol is a selective beta blocker. So to be on the safer side, I will go for that because I don't want any trouble. Because the selective beta blockers will only affect beta 1 cells of the heart and will have no effect on beta 2 cells of the lung.
Okay, thank you very much.
You're welcome. So you're going to control the rates with that. Your verapamil, the usual calcium channel blockers that we know, like the nifedipines and whatnot, they tend to have a vasodilatory effect, right? They are more vasodilators. They don't really have any effect on your inotropic and then your chronotropic factors. but then your non-dihydropyridine tends to negatively affect the inotropy and then the chronotropy. So basically, it would help in slowing down the heart rate, which is what we want to achieve in this case. Okay. So basically, that's what you want to do. For rhythm control, we have medical and non-medical ways of doing rhythm control. Okay, so medical ways, there are medications, what I've given you in your slides. When you look at the arrhythmias, I gave you anti-arrhythmia or antidysrhythmic drugs. So these drugs, you can use them for managing the rhythm, okay? And then in so doing, you are able to control. So you can, go back to those slides, you see that there are a list of medications there, flecainide, amiodarone, sotalol, all of this are used for controlling the rhythm. Then of course, there's the non-medical way where you can actually do a cardioversion for your patient. Okay, so you want to synchronize, you put like an implantable device in the patient, given time, try and bring the patient's heart rate to normal. If the patient's heart rate is not, within a normal rhythm, it just tries to bring it back to normal. So you can do cardioversion for the patient. And then you can also do what we call a catheter ablation. As I said, you introduce something to sort of ablate or burn off the pathway for the neurons that, for the heart to contract, you need your SA nodes, AV nodes, Purkinje fibers, all those things to work. So you can do a catheter ablation to sort of cut off the pathway to prevent the heart from firing too much and firing abnormally. So that's for rhythm control. The most important thing, however, as I said, is that don't forget to anticoagulate your patient. Don't forget to anticoagulate your patient, and deciding to anticoagulate your patient will be dependent on the presence or absence of risk factors. Okay, so of course, the Association of Cardiologists in America, they do well, and they always come up with, nice ways of trying to manage things like that. Okay. Okay, sorry, I was distracted a bit. So basically, if you have a patient who has atrial fibrillation and you think, well, this patient is probably young and doesn't have any risk factor, but it means you need to follow up the patient closely. If a patient has a moderate risk factor, okay, then you need to be a little bit concerned. So you can go ahead and then start your patient on aspirin, right? If sometimes in addition to that, you can either do aspirin or you can do some anticoagulation. I'm sure you're experts in anticoagulation now, your low molecular weight heparins or whatnot, or your warfarins, or even the new oral factor 10 inhibitors like the Xarelto or rivaroxaban and whatnot. But if the patient you think that the risk factor is high, let's say if a patient has had stroke in the past or a TIA in the past, or your patient is old, over 75, these are major risk factors. So you need to put your patient on anticoagulants, okay, which of course we talked about when we get to P. We'll also talk about that, okay. So when we say moderate risk factors, we are looking at people who have conditions like diabetes, very severe hypertension with heart failure, who have, they've had conditions like myocardial infarction in the past, okay, or a patient who has had an amputation because they have some form of peripheral vascular disease. It tells you that all these people have had issues in the past which have led to something like a plaque building up in their blood vessels. People between the age of 65 to 74 are also considered at moderate risk, so you need to put them on some form of anticoagulation. Okay. Are we okay? I'm sure all this was captured as part of your slides. I remember I gave you a CHAT-2 score, okay, to think about when you need to anticoagulate your patient. And this would help you because, as you can see, atrial fibrillation, what is your risk of stroke? With this, you can tell a patient's risk of developing a stroke when they have atrial fibrillation, so you anticoagulate as such. Okay. Any questions, please? Hello. Okay. For a second, I thought my network was gone. Any questions, or I was just talking to myself?
I think it's clear.
Okay. So three things. Rate control, rhythm control, anticoagulation. Just go over the slides. Remember the medications we use for rate control is straightforward. Your beta blockers, go for selective ones. Your non-dihydropyridine channel blockers. You can give Dixenol. Your rhythm control, which is your antidysphomics, which have been used on. We can do cardiovascular, can do catheter ablation for the patient, and the coagulation, which is also very, very important. Okay. And then we'll quickly go on to the next.
I have a question.
Yes, please.
Okay, so are you going to start your patients on all these medications as they go?
All right. Okay, that's an excellent question. So as I said, if you do your patient assessment and you think your patient has no risk factor, you can go ahead and start a rate control for your patient and monitor. Okay, you can start a rate control. You deciding to add something like a rhythm control is dependent on how severe the patient you think the atrial fibrillation is. But some patients do well on just rate control. You understand? But the thing is that for most patients who have atrial fibrillation or who develop atrial fibrillation, you realize that there's some form of cardiovascular risk there. So almost always.
Yeah. Jenny. Hello.
He's gone off.
Hello.
I think I have an issue with my network. Can you hear me, please?
Yeah.
Okay.
Welcome back.
Yeah, I think so. Yes, so basically, as I said, your focus, most of the time, the focus is on rate control, and because most of them will be having cardiovascular issues, you think about anticoagulation as well. Okay, but for people who are like, think that this patient atrial fibrillation is out bad, showing severe symptoms and all that, it's good to, and then some rhythm to their heart rate as well. So you can have them on all the three classes of medication.
Thank you, sir.
Okay. One more question.
Yeah, hello.
Hi.
Yeah, so please, with the risk assessment for the thromboembolytic, the score, how do
Yeah.
you do it? Like, in which
Can you see my screen? Or maybe I have to share it again. Okay, let me see. Someone else is the now. Okay, Nick, the host now.
category will you?
All right, Doc, you're the host now.
Yes, thank
I
you.
made it host now.
Okay.
Yeah, Kwashi, you were saying something else. I didn't hear that. I didn't catch that. Oh. Hello.
Yeah, we can hear you, sir.
I thought he was saying something else.
Hello, Doc.
Yeah. Can you?
Yes. Yes. Thank you very much. Please, I would like to ask, is it possible that there will be a secretion in the trachea with the person having atrial fibrillation?
Well, you won't say that's secretion in the trachea. What I'll say is, if the person's atrial fibrillation is that bad, and because of the atrial fibrillation, the patient has some form of congestive cardiac failure, then you are going to have secretions not in the trachea, but in the alveoli itself.
Oh, okay. Because I'm thinking of in a way where if you are assessing for breathing, and there is a secretion, and how you can do that, because that being an emergency case, how fast you can do that. That is where my problem is. Yes, please.
Fast you can.
How fast you can clear the breathing if there is a secretion in that will impede breathing.
Yeah. Oh, you can. So if you have where you have secretion, if you have secretion in the trachea, okay, you're not going to give patient lasers. You're going for the patient. Basically, you try as much as possible to push your suction tube down and then try and suction. Okay, but it's not the classic thing that you have patients getting secretions in the trachea because of atrial fibrillation. They'll rather have alveolar, excess alveolar secretions, pulmonary, when the atrial fibrillation is leading to a heart failure. Added the secretion bit, added the secretion bits when I was talking about the primary, because once the patient comes to you, you don't know that this patient has atrial fibrillation. So if the atrial fibrillation and has a thrombus, okay, and now let's say has some of embolus, goes all the way, and patient gets a stroke and becomes unconscious there and there. Once you become unconscious, you lose the ability to control the secretions that get into your airway. So the atrial fibrillation can indirectly lead to you in secretion to something like a stroke.
Okay.
When the patient comes to you, you need look at the airway by suctioning. You give your, and then probably you can realize, oh, patient has a stroke. And during that time, patient is recovering, you check the pulse. Oh, pulse is irregular. Patient has a stroke. To find the risk of a stroke. And as part of finding, we know that atrial fibrillation increases the risk so much. Okay, so to try to check pulse irregular. This is atrial fibrillation. It's not, it increases risk of developing a stroke about 5 times.
Okay.
All right. Any? Yes, please.
Please, is it good to do antiplatelet?
Yes, I have moderate risk, and that's what I mentioned. You have age range 65 to 74. They have maybe they're attentive, diabetic, or have had something like a myocardial infarction before. You are thinking about, okay, all right, this patient has moderate risk. Okay, so you can sometimes, ahead and then you give some form of antiplatelets as used in their management. You can actually put it's like aspirin in the management of the patient. Are we okay?
Yes, sir.
Because as I know, you don't really worry about anticoagulation, but if it's moderate, it's just one moderate risk factor. Maybe you think the patient has diabetes and has atrial fibrillation, then you are allowed to give aspirin to the patient. Okay, aspirin about 381 to 325 grams per day patient you allowed. But then if the patient has more moderate risk factors, patient has hypertension and diabetes, aspirin alone won't be enough. So you need to anticoagulate. Okay.
Yes, sir.
Okay. Time is fast spent, so. Since we've been talking a lot about atrial fibrillation and whatnot, let's look at heart failure briefly. And this one, our focus is acute left ventricular failure. So it'll be straightforward. Okay, so brief overview before we go on. So when the heart basically fails to act as a pump, and we say the heart has failed, as we all know. I want to, if I can do it. And so remember we have sided heart failure and we have right-sided heart failure. They all stand for when the left side of the heart fails, then it means that I don't know why my internet doesn't want to open. All right, okay.
So it's a general thing. A lot of people are also complaining that they cannot join a class because of this.
Oh, okay. I don't know. Is it raining outside or does it look like it's going to rain outside?
Well, it did rain where I am, but I don't know.
Yeah. Yeah, I think that's an issue. Okay. Let's see if we happen. All right. So concept of heart. I don't know if it's clear.
It's not clear.
It's not clear. You are breaking.
It's not clear. Yeah.
Breaking what?
Master. Yes,
Buckle.
Master.
Breaking buckle.
You must be here, you are.
Men feel man. Men no.
Come to me.
What day?
Me go did.
Ara.
Me go did.
Yeah, what of DBA?
So then if you treat HIV
Guys, I mean, eh,
Mobile study or what? Mobile study or
Common to Baba no how the class.
as a woo.
Fine boy na ya mother.
fine boy, you treat HIV.
Vigorous for Hawaii.
I don't know which lady is that.
Nick, yeah, HIV is no fine boy.
We say you have right-sided heart failure, then you are going to.
Sorry, dog.
Once you have right-sided heart failure, that's all right. So left-sided heart failure, right-sided heart failure, and then there's also congestive cardiac failure. Once you have right-sided heart failure, you know you are going to have features which are more, associated with the right side of the heart. So you just picture the heart. What is the right side of the heart supposed to do? It's supposed to receive blood, from the vena cava. It receives it at the right atrium. And once it receives it at the right atrium, what it does is that it now moves it to the right ventricles. Okay. And then from there, it can push it through the pulmonary artery into the lungs. Okay. So if you have any problem with the right side of the heart, you basically have issues with congestion in the right side of the heart, and this will backtrack or backflow to wherever the blood is coming from. So backflow into the vena cava, which would, collect blood, venous blood down way to the heart. So it will backflow into it and basically will descend and come to the lower extremities. So in this case, features of right-sided heart failure is going to give you, we are going to see issues with congestion, okay, in the vena cava coming all the way down to, the lower extremity. So you tend to have the edema, okay, which would be bipedal, so bipedal edema, and it can start from the foot to the ankle and go all the way up depending on the severity of the heart failure. So that's one. Also, another feature on the right is that you are going to, as part of the edema, you can develop ascites, and then you can also develop a tender enlarged liver, what we call tender hepatomegaly, right? And then it goes up, 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 and then it can affect your jugular venous pressure. So the JVP becomes raised. So you can see that these features are right-sided features. However, if the left side of the heart fails, then you are going to have congestion in the left side of the heart, which would cause a backflow to wherever the blood comes from into the left side of the heart. And where does the blood come from into the left side of the heart? It comes from the lungs through the pulmonary vein into the left side of the heart. So once the left side of the heart fails, then there'll be congestion in the left side of the heart, and then a backflow into the lungs, basically. And once the backflows into the lungs, you are going to have that kind of feature of what? Breathlessness, okay, because you feel like you are drowning, okay? So basically, those are the kind of features you should have. So right-sided will give you that kind of features we talked about, bipedal edema, ascites, tender hepatomegaly with raised JVP. Left-sided is going to give you pulmonary congestion, features of pulmonary edema, so breathlessness, cough, dyspnea, or autopnea, paroxysmal nocturnal dyspnea, all those features associated with the lungs. In extreme cases, both sides of the lung can fail. So you can have a right-sided heart failure and then a left-sided heart failure together, and we say you have a congestive cardiac failure. So you would have a combination of these two clinical features that we just spoke about. Okay, so basically that's just an overview. Today, our focus is not on clinical features, which we've even talked about, or investigations and whatnot. But yeah, to be able to manage, you need to make a good diagnosis. So I know you do well with investigations, and there are some basic investigations that you need to do if you want to, make a diagnosis of heart failure. So what are some of the basic investigations that we tend to do that actually prompt us or leads us into the direction of making a diagnosis of heart failure?
Cardiac enzyme.
ECG also as well.
Okay. So I had ECG, I had cardiac enzyme. What else can we do?
Chest rate can also.
A chest X-ray. Yes. So echo. Okay. Yes. So that's true. So these are all investigations that you do. And the thing about heart failure is there are myriad of, risk factors or causes of heart failure, which I'm sure you all know you have in your slide. So you do your investigations based on what you are thinking you are dealing with, but some things are basic, like an ECG, a chest X-ray, echo, cardiac enzymes, as you said, if you are thinking about some acute coronary syndrome, which we'll be discussing hopefully tomorrow. Okay. And other features, other things that can cause heart failure, like if you have a thyroid disease, you can have heart failure. So in that case, your investigation, we need to do a thyroid function test. If you have chronic anemia, persistent anemia for a very long time, you can develop heart failure. So in that case, we need to do a full blood count, take a look at the HB and all that. So these are all like features. If you're thinking probably a patient has heart failure, and this heart failure was secondary to an acute coronary syndrome, and the acute coronary syndrome was secondary to hyperlipidemia, then it means that you need to perform a lipid profile, you need to do a cardiac enzyme test, and then, of course, you need to look at other features like the ECG and then the echo. Okay, so basically that's it. In managing heart failure, once you're seeing a stable patient, you don't worry so much. What you are doing is you are basically managing the symptoms and then the risk factors and the etiology of the heart failure. Okay, so in managing heart failure, we know the patient, if the patient has a congested cardiac failure, or if the patient probably has a left-sided heart failure, you want to try as much as possible to clear the chest. If the patient has a right-sided heart failure, the edema and whatnot, you want to, get rid of it. So you give a patient some diuretic, and we usually put them on Lasix, basically. Then we try as much as possible to control their blood pressures. Okay, and then if the patient is diabetic, you want to control the diabetes and whatnot. Okay, and managing the blood pressures, there are specific antihypertensives that we like to give. Something like your ACE inhibitors and your ARBs are known to prevent cardiac remodeling. Remodeling means that the normal myocardium, which is very, very, contractile and moves well and all whatnot, can become remodeled, and you end up having fibrosed or scar tissues in the myocardium, right? And once you have this, we say you have cardiac remodeling. And once you have scar tissue or fibrosed tissue, then it means the heart may not be able to contract and relax as it used to be able to give you an effective, stroke volume and cardiac output. Okay, so your ACE inhibitors, ARBs, are one of the medications that we add for our patients. But of course, today we are not on stable patients. Our focus is on emergency management. And usually a right-sided heart failure alone won't classically present to the ER. The ones that will present to the ER will be an acute left ventricular failure or a decompensated congestive cardiac failure. Okay, so you can have a congestive cardiac failure, but this patient is basically, stable. So your BP medications, diabetes medications, your statins, your antiplatelets would help your patients, your diuretics. These patients won't come to the hospital in an emergency situation. But sometimes it can become decompensated when they have the condition for a very long time, or they defaulted treatment, they have heart failure, which was congestive cardiac failure, but they decided not to take the medications that they gave to them and whatnot. So they become decompensated. Okay, or you can have an acute LVF, and this patient will come to you breathless. Okay, so as a clinician, you are doing your locum, they've woken you up, you go, BP is so high, you have BPs up in the roof, and then the SpO2 is basically around 84%. Okay. What would you be thinking about at that point? Let's say you think, okay, this is an acute LVF. How will you manage the patient? Any suggestions? iPhone wants to talk and McLean wants to talk, so any of them can talk.
So please, as Nick said, you need to first stabilize the patient. So you need to control the BP.
Okay.
Yes.
Okay, so you need to stabilize the patient. But is that what you'll be thinking about? Yeah, so what is it called? You are forgetting the basis of emergency medicine.
Give oxygen before.
You resuscitate.
You resuscitate. You resuscitate. Okay, so Nick, it's good. You want to give oxygen. It's because you don't know that this patient has an acute LVF. Okay. So before you go ahead to give oxygen, you want to know if the patient's airway is patent enough before even giving the oxygen. Because if the patient's airway is not patent and you go and you give oxygen, the oxygen won't get to the lungs, so it won't work. Okay. It's good to control the BP. That's good. But that is crossing all the way from A, B, C towards D, drug therapy. So by the time you give the BP medication, your patient is dead because you fail to assess airway. Are we good? Yes, doctor. So don't forget the basis. It's good. Oxygen is perfect. Control BP is good. But then it has to be in line. Once the patient comes to you, the least of your worry is going ahead to control that. That's the least. You know why? I'll come to that. What happens when the heart fails? I mean, when we say the heart has failed, what do we even mean?
So we mean if the heart cannot provide enough cardiac output to meet the body's metabolism need.
Excellent, excellent. So how would that diminished cardiac output, how would you know that there's diminished cardiac output or there's reduced cardiac output? Per your clinical examination, how would you know?
So the BP.
Good, BP. So you see the point. You have a patient who comes to you with very high BP, but patient is breathless. Your worry is, oh, let me go ahead and then let me give this patient anti-BP medication. And you know the funny thing, if the BP is very high, there are two BP medications that we tend to give in our clinical settings in Ghana. It's either we are giving what? Hydralazine, or we are giving what? Labetal or IV, because we want to bring the BP down. Okay. We are more worried about the high BP. Hey, the BP is high, patient might get a stroke than the breathlessness. But if anything will kill you, the breathlessness will kill you first, even before you develop the stroke. It's good, you have to control the BP. But then again, if you go in all drastic to drop the BP without thinking that this patient has heart failure, and we are saying that heart failure means that it gets to a point where there's diminished cardiac output. So this patient with acute LVF, it will reach a point in that time that you are managing, the BP will just start dropping by itself. So if you go and then you don't think too deep and you start overloading the patient with antihypertensive, by the time you realize your patient has gone into what? Shock. And this shock will be cardiogenic shock, one, because the heart is failing, and then drug-induced, your antihypertensive, drug-induced hypotension. So do you get it? So you always need to basically do your assessment, airway, breathing, circulation, before you get to drug therapy, because that is life-saving. Okay, because even with the fact that BP is high and you are worried about a stroke, so this type of stroke is you are thinking the BP is too high, the blood vessels in the brain will rupture, so you are worried about a hemorrhagic stroke. Remember I told you that infarctive or ischemic strokes are more common. So the fact that the heart is failing, you can end up having some form of poor perfusion to the brain, and you can even have an infarctive stroke. The fact that SpO2 is low, you can have an infarctive stroke. So you quickly need to assess the airway, make sure there are no secretions whatsoever. You listen to the chest. Oh, there are crepitations. Okay. So in my managing of the BP for this patient, let me try and then kill two birds with one stone. Let me give a medication that can get rid of fluid in the lung and at the same time, give me some form of BP control. And that is where Lasix comes in. So your Lasix will basically go and then decongest the patient's lungs. And it controls BP in a certain way. And then of course, once you can see that your SpO2 is going up, your circulation is well assessed, you can think of controlling your BP, and you do it gradually to bring the blood pressure down. Okay. So airway, breathing, circulation, drug therapy. In this case, drug therapy, we are looking at Lasix. Your airway, you've assessed, you've given oxygen. So patients get oxygen going. Usually when the SpO2 is less than 94%, you want to give intranasal oxygen. The way you give the oxygen is dependent on how low the SpO2 is. Okay. So if it's that low, you are thinking of a non-rebreather mask, and then you are increasing your flow rate to about 15 liters per minute. Okay, so the more you go up, because if you start with a nasal prong, you can't increase your flow rate, and your flow rate is about 10 liters per minute, and patient has nasal prongs. No, it's not right. Okay, so you go up to maybe a face mask, a simple face mask. Once you go beyond 10, then you are thinking of giving a non-rebreather mask to your patient, right? Then, let's say you've done that. Patient had acute LVF. You've given oxygen. You've given the patient Lasix, 120 milligrams start. The interesting thing about Lasix is it has a very high therapeutic range, so you can give a very high dose, even all the way up to 240 milligrams without killing your patients. Of course, you need to pass a catheter because you know the patient is going to pee. You don't want the patient peeing on himself or herself or getting up from the bed whilst on oxygen to go and pee. So you pass a catheter. Okay. You give your Lasix, maybe 120 milligrams start, and then you decide to give 80 milligrams later. Fair enough. But then your patient is still a little bit breathless. What else would you do for the patient? It's in your slide, though.
You give IV morphine.
Morphine, good. Well, yes, you give morphine. All right, okay, that's true. You give morphine to the patient. It's something that has been done all the way in the past traditional era of medicine till now, even though now people are raising a lot of questions, why are we giving morphine? And people are doing lots of studies. It's still in the textbooks. You give morphine. Why? Why do you give morphine to the patient? It's very essential that you know. So I know we are tired, but we are about finishing. We'll finish soon, okay? I know people will say, hey, Kaminta, when he gets us, he doesn't want us to go. He just wants to teach some. So,
Don't worry.
No.
Don't worry. We also enjoy. We also enjoy listening.
No,
So
we are
feel free.
we are almost done. We are almost done.
Yeah.
So two main pathophysiologies. I mean, if you go back to your heart failure, so I gave you 5 things to look out for in the pathophysiology. But let's look at these two concepts: the concepts of preload and the concept of afterload. Okay. So preload means that the amount of blood that is getting into the right side of the heart before the heart will contract. That's what it means. Okay. And then afterload is the pressure in the blood vessels. That's basically the left side of the heart is supposed to contract against to be able to force blood out of the left ventricle into systemic circulation. Did you get that? So preload is the amount of blood that is going to enter the right side of the heart, right? And you know that the amount of blood that enters the right side of the blood is what determines the contractility of the right side of the heart, Laplace law, pressure, all those things, all those funny things. Okay, Starling's forces, all those funny things. So
let me see if I can take it from here.
So
when you give them morphine, it will reduce the activity of the sympathetic nervous system and lower both the preload and the afterload.
Okay.
Hello, Doc.
I'm trying to think around it to see if the mark is over 3, to see if I can give you 1.5 over 3.
0.5.
Oh, 1.5.
No, I mean, as part of the pathophysiology, sympathetics also come in when you are talking about heart failure. And that's what I'm trying to think about it and see if I can give you a mark. Okay, but then with the concept of preload and afterload, okay, it means that when the heart is failing, okay, cardiac output is what? Falling, right? We all agree when the heart is failing, it means cardiac output is what's falling.
Yes.
And for us to increase cardiac output, we all agree that we need more blood to enter the right side of the heart or the left to improve the contractility. We said the more blood that enters, the more it's like a balloon. So the more it expands, recoil, and the more it can contract and push blood out. We get that principle, right? So when the heart is failing, okay, the sort of preload will sort of increase just to increase the ability of the ventricles to contract and push more blood into the systemic circulation to increase the stroke volume. Basically, that's it. But you see, the thing is that your body has forgotten that your heart now is already weak. So increasing the preload and getting more blood into it will rather worsen your condition. Do you get the principle? Ideally, the more blood that enters to contract and the more blood that gets into the circulation, or the more stroke volume, and it means the more your cardiac output would go up. That's a principle. So it's like if you put less inside, you're going to get less stroke volume and less cardiac output. But if you fill the heart more, it's like you go to church and then you give more to God. You give more and then what? God will bless you more. That's what the Christians believe, right? Okay. So the more you increase the preload or the blood getting into the heart, right, the more you are going to stretch the ventricles, and the more you are going to increase the recoil velocity of the ventricles, and the more blood you are going to push into systemic circulation. The body knows this. So as soon as the body feels that, I'm not perfusing my organs right, I'm sure my heart is failing, I'm sure something is happening, as a compensation, it tries to increase the preload just to increase the amount of blood getting into the ventricle so that your ventricles will be able to contract, recoil nicely, and then push more blood into circulation. But you see, the body has forgotten that the heart itself, the strength is not so good. So if you end up increasing the preload, you are going to worsen the heart failure that you have because you are going to have a congested heart, which ideally should be able to put more pressure on the ventricles to contract. But in this case, because the heart has failed, the ventricle is failing to act as a pump. Are we okay? Or we are confused?
Well, we are okay. Yeah, we are okay.
Good. All right, good. So
Ideally, is
ideally,
this all for the reason why we are giving them morphine?
yes, I'm coming to that.
Oh, okay.
So don't get confused, but it's for the morphine. So ideally, preload is good. Increasing the preload is good because increased preload will mean that increase, pressures in the ventricle, increase recall, and then increase stroke volume and cardiac output. We all agree. So ideally, this is good. Okay. But in the case of heart failure, because the myocardium has failed, it's failing to act as a pump, increasing stroke volume at that point will not be so good for us because it's rather going to cause congestion of the heart. And then, of course, this will cause backflow and it will cause the edema and whatnot. On the left side, it's going to cause pulmonary edema. On the right side, it's going to cause dependent edema. So what does morphine do? So morphine comes in and then morphine reduces the preload. How does morphine reduce the preload? Morphine has an ability to cause your blood vessels to vasodilate, especially the veins. So like the inferior vena cava, which is pumping all the blood to the right side of the heart, or causing the preload. When it becomes dilated in the dependent part, it means it would enlarge and the more blood will pool in it and you will have a reduced preload. Do you get it? So the blood that, ideally the inferior vena cava is supposed to push, contract, and then force it into the right side of the heart to increase the preload. Morphine will rather cause the opposite and cause the inferior vena cava to relax and open and fail. So there's decreased preload. So you have reduced or diminished amounts of blood coming to the right side of the heart. That will diminish the preload, and then the patient is actually not going to have that kind of breathlessness because basically that is what is going to happen. It would happen on the left side. So the patient who has acute LVF, the morphine is going to act on the vessels in the lungs and then cause some form of, dilatation and whatnot. I mean, this would help the patient and then it would prevent the stasis when you are looking at it from that point of view. It will basically prevent the blood flow and whatnot. Okay. Does it make sense?
Yes, so please, I'm a little bit confused here.
Okay.
When you look at this, one side effect of the morphine is it decreases the respiratory effort.
It causes respiratory depression. Yes.
So, given it while the patient is having a little
bit of respiratory challenge. Yes, and that's why.
So is it not going to worsen the case?
The case. Okay. So thing is, it doesn't worsen the case. If you are doing your normal dose, you are not overdosing the patient or becoming overzealous, because as I said, it's something that has been used and in the past. It's still in our textbooks, but now people are raising questions like the question you just raised. But they still keep doing research. And when you just take between your 5 to 10 milligrams start for the patient, you are okay. For me, I like to play safe. You give a patient 5 milligrams after the Lasix. Most of the time, there's perfect improvement and the patient doesn't have any form of respiratory depression. And as I always say, if you just do the Lasix and your patient is going, at that point, if you have morphine, will you say that, hey, if I give them morphine, they'll respiratory depression, so I won't give? You are losing your patient. And morphine has been proven to cause some form of venodilatation, and this would increase, the capacitance of your venous vessels and decrease the preload. You get it? So why wouldn't you give? Because you are losing your patient. You give, but you make sure you've given the right dose and you document, so nobody can blame you. It's a standard practice.
Okay. Yes, please.
Good. So yes, so you give morphine, and that's the reason why you give morphine. I think someone else has a question. Yes.
Yes, I want to know, instead of morphine, the vasodilatation, we're thinking of that effect. There are other medicines that are also capable of dilating the blood. So can you opt for those ones instead of the morphine?
Yeah, you see, the thing is that if you look at how the morphine is actually going to work, that is the kind of feature that you want. You are thinking of maybe giving the other vasodilator you are thinking of is probably giving hydralazine, right? Or what are you thinking about?
Yes, sir. Yes, sir.
Yes. So it's not a bad thing, because even as we're saying, the BP is so high, and even if you are going to control your BP with IVs, and you have to choose between hydralazine and then labetalol, you give the patient hydralazine, because if you go and give labetalol, which is a non-selective beta blocker, you are going to push your patient. Okay, so you give hydralazine, which is a vasodilator. So that will give you some form of vasodilatation and regulates the BP in a way. But most of the time, when you have an acute LVF, it doesn't really sort out the problem, even though it has that kind of vasodilator effect. That will rather affect your blood pressures, but then it won't give you that effect you expect to get from morphine.
Okay.
So, sir.
Yeah.
We are saying that the baseline of the morphine is to relieve the patient from breathlessness, right?
Exactly.
Okay.
So once you give, because it's morphine you've given and it's an opioid, there's a risk of the patient vomiting. So you need to add an antiemetic like metoclopramide for the patient. Okay.
Yeah, look, I want to ask if I have given my needs and I don't have access to more, will it be good if we to give a B2 to
Will it be good to give
challenges, the breath challenges?
I didn't hear that. What would you want to give instead?
D2 short dose.
Well, a beta 2 agonist. Hello. Hello. So that was a good question, but I don't know. I couldn't hear the end of the question. Okay, any more questions?
Say, what of the nitrates?
We like
What of what? Nitrates?
Yes, the nitrates.
Yes, as a vasodilator.
Yes, sir.
Which of the nitrates would you want to give?
Either glycerol trinitrate or isosobite.
All right, okay. That's good thinking. But that would usually not affect the major vessels you are targeting. So if your acute LVF is probably due to some form of, vascular condition like a myocardial infarction or whatnot, which usually your glycerol trinitrate or isosobite might not really have any major effects, because we are looking at an acute coronary syndrome. There's a blockage there. Okay. It won't really help so much. Your nitrate will help when you are dealing with your stable anginas. If you remember the slides you have.
Yes, sir. Yeah. All right. Thank you, sir.
You're welcome. So, I mean, once managing acute LVF is straightforward. Once you do your primary survey, airway, breathing, circulation, you manage that, you start giving oxygen. Next thing is you are giving Lasix. So don't delay giving Lasix. Next thing is you are managing your BP. Okay, so if it's that high, you just want to give a little bit of hydralazine to let it, calm down a bit. Try as much as possible to avoid labetalol in that state because you kill the patient. Okay, and then once you give that, you can go ahead because hydralazine is short acting. So the focus is now trying to switch the patient to a long acting antihypertensive medication, right? So you can go ahead and then you give whilst you are thinking of prevention of cardiac remodeling. So you are giving your ACE inhibitors and then your ARBs as well to the patient. Okay. And then once you've managed the patient, after about 3 days, you can put the patient on selective beta blockers, those ones that won't affect the lungs in any way, like the metoprolol and your atenolol and bisoprolol to help regulate the heart rate. Because once the heart fails, the heart keeps beating faster. Basically the heart cannot keep up with the heart rate. So you need to try and then control or regulate how the heart beats. Okay, in addition to your ARBs or your ACIs for the patient. So any question before we go? A question that wasn't able to come through, I think hopefully tomorrow when we have the next session, we can ask. I think time is fast spent. We can discuss the third topic we're planning to have, which is cardiac arrest. Hopefully we will have a 1-hour session tomorrow, and then we can discuss cardiac arrest and then management of coronary syndrome, which is also straightforward. I mean, basically, we've touched on the most important aspects of cardiovascular emergencies. Your ABCDs and your D in most cardiovascular emergency are thinking of Lasix and BP control and whatnot. So shouldn't be a problem tomorrow. So we'll end the class here today. I hope I get a stable internet tomorrow and then we can have a session. Okay. So good night.
Sure, sir. Good night. Bye.
All right. Good night.
Good night.
Thank you, sir. Good night.
Good night. Enjoy your night.
Okay. Thank you.